In this chapter, we will be discussing urinary tract infections. This is chapter 37 in the Mahon textbook. We're going to start out with definitions. UTI is urinary tract infections, and it's a spectrum of diseases caused by bacteria invasion of the genitourinary tract. The upper urinary tract includes the renal parenchyma. So the inflammation of the renal parenchyma is called pyelonephritis, and the ureters. And if there's an infection in the ureters, it's ureteritis. Symptoms include fever, flank pain, and tenderness. Lower urinary tract includes the bladder, which the inflammation of the bladder is called cystitis. The inflammation of the urethra is urethritis, and in males, the prostate, prostatitis. Symptoms include pain on urination, increased frequency, urgency, and suprapubic tenderness. Bacteriuria is defined as the presence of bacteria in urine, and it may be symptomatic or asymptomatic. You need to be familiar with the anatomy of the urinary tract, and this should be very familiar by now. But please note that the urethral mucosa is the most susceptible to infection in the urinary tract. The urinary system is resistant to colonization and infection because of the characteristics of urine, which is hypoosmolarity, a low pH that inhabits pathogens, that acidic pH. It's very dilute, so urine fails to grow most bacteria. Men have prostatic fluid that is inhibitory, and the flow of urine has a washing effect. And notice this is a bag with a urine sample in it that is appropriately delivered to the laboratory. No leaking. Wonderful. Different age factors come with different risk. So for infants, boys have a higher incident rate of urinary tract infection due to uncircumcision. Preschool age children, girls, are more infected than boys. Most renal damage due to urinary tract infections can occur at this age. For school-age children, girls are more prone to develop UTI upon sexual activity. And adults to 65, there's very low incidence unless there are genital urinary abnormalities. However, in the over 65 age group, UTIs increase dramatically in both men and women. There's an atypical presentation, so there may not be any indication that there's anything going on with their urinary tract system, but they can have fever, delirium, and just a failure to thrive. It's very interesting. For males, they have prostate changes and increased catheterizations. That can lead to neuromuscular changes that can increase urinary tract infections, and females can have fecal soiling and increased catheterization as well. Again, neuromuscular changes and bladder prolapse in women. Other risk factors, if you're in a hospital or nursing home, any kind of institutionalized care, you have an increased risk of urinary tract infection. Also, pregnancy and renal transplant. Other risk factors, high ammonia concentration, lowered pH, so if it becomes more basic, decreased blood flow in the renal medulla, and this results in reduced chemotaxis of white blood cells and reduced bactericidal activity of the white blood cells. The clinical signs and symptoms are also different for the different age groups. Infants and children less than 2, you'll have nonspecific symptoms like failure to thrive, vomiting, tiredness, fever. Children over 2 are likely to have localized symptoms such as dysuria, increased frequency, abdominal or flank pain. Adults with lower UT infections, they have dysuria, frequency, urgency, and sometimes suprapubic tenderness. Adults with upper UTIs will have flank pain and tenderness and fever, especially those with acute pyelonephritis. Acute glomerulonephritis results from an immune response to Streptococcus pyogenes or group A strep infections, either respiratory or pyodermal. The signs are edema around the eyes, blood in the urine, and red blood cell and white blood cell casts. There are 3 access routes pathogens have to the urinary tract, and the 3 access routes are the ascending, which is most significant, usually seen in females since the ureter is shorter, descending, which also is referred to as hematogenous or bloodborne. This occurs as a result of bacteremia. Less than 5% of UTIs happen this way. And then lymphatic. You have increased pressure on the bladder, which causes a redirect of lymph fluid to the kidneys, and that would be pretty rare. Flora of normal voided urine. So if you don't get a clean catch, if it's just a voided specimen, you are very likely going to get some contaminants. So you would expect Staphylococcus epidermidis to be the predominant bacteria in voided urine. You also may see some alpha hemolytic streps or now non-hemolytic streps, definitely Enterococcus, lactobacillus species, diphtheroids, and yeast. So the point is that you need to be able to pick out the contaminant. Yeast can also lead to candidiarrhea, especially in hospitals where there's increased antibiotic use. Candidiarrhea can indicate bladder or renal infections, urinary tract fungus balls, or disseminated candidiasis. So don't forget about yeast and other fungus that can really wreak havoc on the urinary tract system. E. coli is the #1 cause of uncomplicated urinary tract infection, so that means just the average patient or the average person is more likely to get a urinary tract infection from E. coli. Enterococcus usually affects older men with prostate problems, so that's a very common one. And then we've talked about Staph saprophyticus previously. Staph saprophyticus is the most common UTI in sexually active women, so you need to make sure that you remember those 3. For specimen collection, you need to collect the specimen in a way that you prevent normal vaginal flora, perianal, and urethral flora. So again, we need to get a midstream clean catch, and if it's self-collected, remember the patient needs good instructions. This is the most common sample collection, and it can be difficult and not done correctly. For catheterized urines, the sample must come from the actual port, the actual catheter, the port that's coming out of the urogenital tract, urinary tract, not the bag, because catheterized urines are at the most risk for skin contamination. So port, not the bag that's been hanging by the hospital bed all day. And then suprapubic aspiration is only for anaerobic culture, and there should definitely not be any contaminants in either a cath urine or suprapubic aspiration. For specimen collection, I used to love these when I worked in the lab. If you got a urine cup with this, it sometimes would come with one of these gray additive tubes, sodium borate. It keeps the integrity of the urine for culture up to 48 hours, and these cups can leak so often, and then if the cups leak, you can do the urinalysis, but not the urine culture. So remember that the gray top uses sodium borate, and it can be stored for 48 hours. Transport, if it's not processed or preserved within 2 hours of culture, you need to refrigerate that. So why do we even do a urine culture? Because it's so common and we usually know what antibiotics will work. Well, there are 3 reasons: to confirm the cure, to detect asymptomatic bacteria in pregnant women, and to evaluate the bacteremia, fever, or both. And here, this is I took this picture in lab about 7 years ago, and this is a beautiful urine streak. For pre-culture screening, so many times you will get a urinalysis with culture if indicated, so you need to know if a urine culture is indicated or not. So first we do the screening, and there's the routine urinalysis. Within the chemical screening, the leukocyte esterase and the nitrate on the urine dipsticks serve as screens for whether or not we need a culture. And in the microscopic urine, if we see white blood cells, if we see 5 to 10 white blood cells per high power field, that could indicate we need a culture, and also the presence of bacteria. The automated methods, we have semi-automated methods in the lab, but they're expensive, and the labs that do a lot of urines usually have these. Gram stains are generally not performed on urine. So causes for rejection. We will be probably, I would guess, urines are one of the most commonly rejected samples if there is inadequate method of collection or transport. So if it's been sitting around too long, or we really don't know if it's been inadequately collected. Of course, labeling incomplete if there's no patient name, source, accession number. I mean, because we need to know the source. Is it a cath urine? Is it a voided urine? Is it a clean catch? We have to know that, because that's going to determine whether or not we work up certain organisms. Insufficient volume. We're likely not to get insufficient volume from culture, because really it takes 3 microliters to do, at max, to do a urine culture. 24-hour urines, pooled urines, and cath tips are rejected for urine culture. And also, I also took this picture to the left. This is what you're going to get a lot. The lid was not put on correctly. The urine has leaked into the bag. There's still some in the cup, but you don't know if that is sterile any longer. So you could do a urinalysis on this, but definitely not a culture. And you'll need to explain that to other healthcare professionals. So how do we set up a urine culture? You're going to need at least one selective agar, which will be Mahon Ch, because what's the most common cause of urinary tract infections? E. coli. And what plate is selective for gram-negative bacteria? Mahon Ch. And E. coli is a lactose fermenter, and we can look at it quickly. Also, at least one non-selective agar, blood agar. And also, they make these, which is half blood agar and half Mahon Ch, and this is called a biplate. You will see these at clinicals being used some places, and other places just use the old system. Some places may do a blood and Mahon Ch only for, and what's going to grow in the blood? Everything. What's going to grow in Mahon Ch? Gram-negative rods. And they may add a CNA, and what's going to grow on the CNA? Gram-positive organisms. So for the urine culture procedure, you're going to inoculate using either the 0.001 ml, that's the 1 microliter loop, or a 10 microliter loop. Now, everywhere that I've worked, and I think all of our clinical places, use the 1 microliter loop onto a selective and non-selective media like blood agar plates or Mahon Ch. So you dip the calibrated loop into the urine, make a single streak down the middle, and then streak back and forth across the plate perpendicular to the original line, creating a lawn of bacteria. With the same calibrated loop, you do the same with the Mahon Ch plate. Now, some places will only streak the blood agar plate for the colony count, but usually when I'm just on a roll, I just streak all my urines that way. Then you incubate at 35 degrees Celsius for 24 to 48 hours. And this is what you might see the next day. This is really, I did these, I'm so proud. This is probably a Staph aureus, but that doesn't matter. We did get some isolated colonies, and we did get some isolated colonies over here, and so this is a really good urine streaks, what you should expect. Okay, so what do we do if there's no growth? If there's no growth at 24 hours, we're going to do a preliminary report as no growth at 24 hours, and then re-incubate for another day. Then at 48 hours, if there's no growth, you'll turn out a final report that says no growth at 48 hours and you can throw away the plates. So what if there is growth? You're going to ask yourself, what media has growth? If there is growth on the blood agar plate only, this rules out the enteric pathogens because gram-negative rods colonies may be gram-positive or gram-negative, but if you don't have any growth on McConkey, then that is going to rule out your Enterobacteriaceae. If you have growth on blood and McConkey, most likely there's an enteric gram-negative rod or Pseudomonas. If there are more than one colony type, you might need to do a gram stain. So then the next question you need to ask is, how many colony types are growing? And I'm going to flip to the next picture to discuss this. So if there's a specimen with greater than 3 organisms growing, there's probably a contaminant and you don't need to do the identities and susceptibilities because it's contaminated. If there are 1 or 2 pathogens with greater than 100,000 colonies per mil, then you need to identify that. And the plates that I showed you, let's back up. So these plates have only one type of bacteria. They're greater than 100,000 colonies. This probably has maybe, I would say, 50,000. Only one kind. You're going to work that up. Okay, so, but how many do we have here? We have one, this big gray one. I see colonies, and there are others that look like that, but there's at least one. And then here's another type. I see quite a few of these. It looks probably like it's beta hemolytic. And then what else do we see? I see this white, so there are bigger white colonies around, so that's another type. And then there are these little tiny ones that are kind of hard to see. There's this area here. Here you can see that it's like they're sprinkled around the rest of the colonies. So we would just say contaminant, urine culture is contaminated, need to recollect if that was a voided urine. If this was a cath urine, you're in for a lot of work. All right, so how do we determine the colony count? So do we actually count the number of colonies on the plate? No, like for this one, you don't really count all that. You're gonna do whatever they teach you at clinicals at your particular hospital, but places that I've worked, you kind of divide these into like of quarters, or you just look at it and she goes, there's about 75% of the plate covered, so I'm going to say that's 75,000 colonies. But what we should really do is count if there's 72 colonies, we would count 72 after an incubation period. We would count 72 colonies. And then what would the colony count be? 72,000. Just really easy. If you're using that 1 microliter loop, that's a 1 to 1,000 dilution. 72 times 1,000, 72,000. So what do we consider for urinary tract in urinary tract infection in urine cultures? The colony count of pure or predominant organism, the measurement of pyuria, and the presence or absence of symptoms. So how do we determine if there is an infection? Symptoms, predisposing factors, and the organism isolated. And that concludes urinary tract infections.